Thanks, Tom. I'm going to talk to you today about our clinical trial, which we've recently completed, looking at the role of inhaled tiotropium in bronchiectasis, and we've called it the ROBUST study. These are my disclosures. I was a member of and chair of the Independent Scientific Committee for an annual respiratory workshop, which was sponsored by Boehringer. Boehringer makes the drug that we studied, but they didn't supply us this drug, and they didn't sponsor our study, and we were funded by the HRC. So bronchiectasis is derived from the Greek words bronchus and ectasis, which you can see there, which is stretching or distortion of the bronchi, and it's associated with chronic inflammation. They have chronic sputum production, a lot of inflammation there, and recurrent bacterial infection. So inflammation and infection are key factors, and about 2/3 will also have airflow limitation. And from our previous study, we found that 65% had airflow limitation defined by an FEV1 divided by FVC of less than 70%. So tiotropium is a long-acting anticholinergic agent. It's highly effective in COPD, and it works on the muscarinic receptors by blocking them for 24 hours. So you take it once in the morning, it lasts all day. And it pretty much blocks a variety of receptors down the vagus nerve. But the most important ones are the M3 receptors on the smooth muscle of the bronchi. So when you block those, the muscle relaxes and you get bronchodilation, which lasts for 24 hours. It's been postulated that there are some anti-inflammatory effects in the laboratory, but they've been difficult to show clinically. And what we know about tiotropium is that it's highly effective in COPD, so chronic obstructive pulmonary disease due to predominantly smoking. It's a similar condition to bronchiectasis in many ways. It's also got differences. It's not smoking related in bronchiectasis. But the key factors are that you have airflow limitation in both conditions. You have neutrophilic airway inflammation in both conditions. Chronic infection is an issue, and mucus hypersecretion. So there are similarities in those. Now, if you look at the data in tiotropium is extremely strong in terms of randomised controlled trials. It pretty much improves any clinical endpoint you want to look at. So it improves dyspnea, exercise tolerance, quality of life, exacerbations, and mortality. So it's become first-line treatment for COPD for many respiratory physicians. So this is the design of our study. So our primary aim was to determine whether tiotropium inhaled reduced exacerbations and improved lung function. And the patients we selected had to have bronchiectasis and airflow limitation. It was a multi-centre study, randomised controlled, and we did a crossover to get the adequate power. So we had a baseline of stability for 6 months, then patients were randomised either to tiotropium or placebo, and after 6 months there was a washout period of 4 weeks, and then they crossed over to the other treatment for 6 months. These were our inclusion criteria. We enrolled adult patients with bronchiectasis. They had to have at least one exacerbation the previous year, and that's a marker of prediction for a future exacerbation. So we want to increase the risk of them having exacerbation so we could pick up any reductions. And patients had to have airway narrowing as defined by that ratio. We excluded patients who had a history of more than 20 pack years. So there's this risk in the study of having COPD patients treated as well as bronchiectasis patients. We wanted to limit the smokers so that we didn't show an effect of just tiotropium in those patients. There's a postulated risk of cardiac arrhythmia with an anticholinergic agent. We excluded those patients, and allergic bronchopulmonary aspergillosis and non-tuberculous mycobacteria as a cause for bronchiectasis. So we had predominantly idiopathic and post-infectious bronchiectasis. These were the endpoints. So the primary endpoint was exacerbation frequency or rate, FEV1, so the spirometric data, and then we had a variety of secondary endpoints: time to first exacerbation, exercise capacity. We had 3 quality of life questionnaires, and we were looking particularly at adverse events as well. So this is a trial profile. So we had Waikato, Auckland, and Middlemore hospitals involved in the study, and we randomised our target of 90 patients. And remembering that all 90 patients had the treatment and all 90 patients had a placebo period. But if you can see that you randomised to a sequence, either tiotropium first or placebo first, and then go down to the end. And we had 5 dropouts overall, about a 5% dropout for the whole study over the 1 year period. So this is the baseline data comparing the two sequences, although all patients had both placebo and tiotropium. So bronchiectasis typically is characterised by predominance of female patients, and that's borne out here. We had an average age of about 60 years. Now smoking, we had about 40% of our patients were smokers or ex-smokers. Most were actually ex-smokers. But if you look at the pack years, the total amount of smoking in the smokers only, so this is data for only the ones who smoked, the average pack years was only 6. So we had very low smoking rates in our bronchiectasis patients. Exacerbations in the past year were about 2 to 3. Lung function was moderately impaired, around 60%. They had good exercise capacity, so their 6-minute walk test, which is normal if it's over 500, was good in these patients. Now, in terms of respiratory medications, about 50% were taking, 40-50% were taking a long-acting beta agonist, which is also a bronchodilator. And only a small proportion were using a mucolytic such as mannitol, which would increase the sputum production. So these are the results. Oops. So the primary endpoint was exacerbation rate. So we had expected to see, our hypothesis that we would show a reduction in exacerbation rates. We didn't see that. In fact, we didn't see really any effect on exacerbations. You can see that the numbers are very similar. There was no significance in that. When we looked at lung function, we did show an improvement, so we could show that there was bronchodilation, about 58 mils over the 6-month period between the groups in favour of tiotropium. Now that's statistically significant, but the clinically significant cutoff is around 100 mils. So this is statistically significant but not clinically significant. What about secondary endpoints? So again, we showed that forced vital capacity was improved, again showing that the tiotropium was actually working in terms of bronchodilation, but we didn't see any effects on our secondary endpoints. So there was no improvement in time to first exacerbation, exacerbation duration, the exercise capacity is measured by the 6-minute walk test, the symptoms or quality of life, and we measured the 3 standard questionnaires. The St. George's and the Leicester-Cough questionnaires are validated questionnaires in bronchiectasis. The COPD CAT test is validated in COPD. What about adverse events? So it's generally well tolerated, as we expected, because we use it a lot in COPD patients. There was no difference in the adverse effects between events between the two groups. We had a number of serious adverse events, which is defined as a hospital admission, 8 in the tiotropium periods and 3 in the placebo, but none of those were felt to be directly related to medication. So they may have come in with a cellulitis or appendicitis, etc., but nothing directly linked to the medication. So in conclusion, our patients with bronchiectasis who had airflow limitation did not have a significant effect in terms of exacerbations, improvement with tiotropium. Tiotropium improved lung function modestly, but probably not clinically important. We didn't see any improvement in symptoms, exercise capacity, or quality of life. So what does this mean? So tiotropium, we shouldn't probably prescribe this routinely in patients with bronchiectasis and airflow limitation, as we would typically do with COPD. This may have importance in terms of the mechanism of an exacerbation. It's likely that there's a difference in COPD and bronchiectasis. So in COPD, the mechanism of exacerbation is probably airflow limitation. So bronchodilating them prevents exacerbations. However, in bronchiectasis, this suggests that it's much less likely to prolong, even in these patients who have airflow limitation. And it's likely that it's more related to what's being termed respiratory dysbiosis in causing exacerbations, where it's a complex system where you have commensal microbiology, you have pathogens, you have immune function, and you have clearance mechanisms of sputum. And this would support the fact that it's more likely to be around the inflammation and microbial mechanisms for causing exacerbations. And I'd just like to finish by acknowledging multiple people who have participated in our clinical trial. Thank you. Jeff.
It's obviously hard to look at potential difference in exacerbations in FEV1, but how
It's interesting. So we powered primarily to the exacerbations and lung function. We didn't power to the secondary endpoints, but we didn't see any signal in the secondary endpoints. So normally we in other studies you will see some signal in terms of going in the same direction. We saw a mixed direction across the secondary endpoints. So I think that I don't think there was a real effect that we weren't picking up because of power.